I talked to Michael Bayless yesterday. Oh, good. It was great. He's a very cool guy. He had these sounds like that.
Yes.
That is their problem.
Yeah. All right, so grand light.
All right, well, hello everyone, welcome. I'm glad to see such a engaged group, so many people here. So I want to introduce my own colleague, Dr. Oli Fein. So Oli is a professor of Emeritus at Weill Cornell Medical College and a past president of the Physicians for a National Health Program. He's also the past vice president of the American Public Health Association, served for 4 years as a board. So Oli's work is going to focus on questions around delivery system and payment reform for vulnerable patients, but mostly we're going to focus on strategies to provide access and coverage for Americans. It's been tirelessly involved in this work and research and advocacy and public speaking role for many years. And so Ali gave grand rounds today at Miriam, and we get him as a twofer. So I'm thrilled that he could come over to public health and be with us today. So Ali, why don't you come and give me a talk? Thank you so much. Yes.
No, okay. You want to? I just wanted to see you.
Just that, I am also fundamentally a clinician, and really was involved with my clinical practice until about a year and a half ago when I was an emeritus professor. So my interest has been in healthcare, delivery, and my patients.
Learning your background. People couldn't see.
All right, so, and in terms of my disclosures, I don't believe I have any relevant financial relationships with commercial interests. But as you have heard, I was the chair until really 4 months ago of the New York Metro chapter of Physicians for a National Health Program, and was the past president back in 2008 and 2009 of the national organization. But I have received absolutely no, financial compensation from DNHP. If anything, I've donated money to it. So what are we going to do this noontime here? We're going to talk about what I think are really four of the really principal problems facing the U.S. healthcare system: persistent uninsurance, growing underinsurance, variable quality and poor outcomes, and the high cost of care. And then we will talk about what are some of the policy options to deal with these four very major problems. And we'll talk about Biden and how he has tried to build on the Affordable Care Act. We'll talk about Trump, although it's a little bit difficult to know what he's going to do if he achieves the presidency. But I think the Republican Party at this point would like to privatize the Medicare program. We'll talk about that. And then talk about an improved Medicare for all, and as a policy solution. And although we don't really have time, there is the whole question of Well, if we can't do it on a national level, maybe we could do it on a state level. And it turns out New York State does have a proposition to do that. We have legislation that has been used, but we won't have public time to talk about it. I think the state of New York. So, starting out with the major problem as I see it, though one of the major problems is uninsurance. And if we look here at things, prior to 1940, there was actually virtually no health insurance in the United States. Now, it is true that in 1929, Blue Cross was founded. Blue Cross, a non-profit private health insurance entity that only covered hospital care. And during the Depression, there was the growth of unions, and unions actually wanted a fringe benefit. In fact, they wanted two fringe benefits. And what do you think they were? Health insurance. Anyone have a guess what the second one was? Retirement pension. Yeah, pensions, retirement benefits. And then along comes World War II, and the unions are not permitted to bargain for wages, but they can still bargain for fringe benefits. And I think that was at least a catalytic element that linked our health insurance system to employment. You notice that all the other industrialized nations do not link health insurance to employment. And then interestingly, post World War II, another entity was created, I'll just mention this, called BS, right? What was that? Bullshit. What was BS? On our guess. Blue Shield. And how does it differ from Blue Cross?
Covers doctors.
It covers doctors and outpatients, examinations, and medicine and laboratories. Interestingly, did not cover prescription drugs. And then you see this catalytic occurrence. In 1965, the passage of Medicaid and a huge increase in the uninsured in the United States. And then it goes up about 1 million more uninsured until 2010. That's when the ACA was passed. There was a big challenge, and it requires a report date. That took about 2 or 3 years. And it's only then that it was fully implemented. But the ACA never got us to zero uninsured. And the other thing to know and note about our uninsured population is the huge disparity by race. So that you see here about 5% of whites are uninsured. But close to 10% of Blacks are uninsured, 18% of Hispanics, and surprisingly, Native Americans at 20%. And that's because the vast majority of Native Americans now live off of reservations where they have guaranteed health care. So, looking in addition to how does the really poor population in this country get health insurance is actually through the Medicaid program. And you can see how that program has grown to the point where it is the largest public health insurance program in the United States. How many people are insured by Medicare? Only 51 million. And what you see here is that we are now close to 88 million Medicaid patients. public insurance. Well, uninsurance is truly a bad thing. But I think in addition to that, we are experiencing an epidemic of underinsurance. And what you see here is how the price of average annual premiums for a single person, $8,435 in 2023, and $23,998 for family coverage. Can you imagine that? And when you compare it, with 1999, you can see how it was drawn up almost before where it was back in 1999. But this chart, I think, is even more revealing. Because what you see here is that family premiums have gone up since 2013, in the last decade or so, to 47%. And what's happened is that, workers' earnings have only gone up 42%. And inflation has eaten away 30% of those wage increases. And then, in terms of deductibles, and you all know what a deductible is, I hope. It's the amount of money that you have to pay out of pocket before the health insurance actually kicks in. And that has gone up 78%. So, and then here, looking at the average annual deductible for workers enrolled in single coverage, what you see is that on average, the deductible is $1,500. If you work for a large firm that can negotiate with the insurance companies to get the deductible lower, it's about $1,200. And if you work for a smaller company that can't negotiate lower rates with the insurance company, it's up to $2,120. And it turns out that many American families can't afford this level of out-of-pocket costs. If it's $2,500, one half of non-poor families don't have the liquid assets to take out of pocket to pay. And if they have no insurance, it's 81%. And then if you think of out-of-pocket payment limits, some insurance says, you won't have to pay more out of pocket than $6,000, others say $12,000. That percentage, 63% of Americans don't have that kind of out-of-pocket money that they can pay. And it goes up to 89% if they have no health insurance at all. We are underinsured, and little wonder that the major cause of personal bankruptcies in the United States, 2/3 of them, are due to lack of health insurance for the loss of work and loss of health insurance. So what you see here is that 36% are bills and work loss, and 22% actually are medical bills alone. They have insurance, but they're underinsured. And it's only really 1/3 of the population where there was no medical cause to their bankruptcy. Absolutely astounding. So uninsurance and underinsurance result in really poor outcomes. And so when you look at it, here it's attributed to 38,882 deaths in 2019 were due to uninsurance. And in the state of Texas, which had the largest percentage of uninsured, 18%, they had 6,731 excess deaths. And when you look at it in terms of life expectancy, we have the lowest life expectancy of most of the industrialized nations. Absolutely without in terms of the outcome of health care in the United States. And in terms of infant mortality, we have the highest infant mortality, 5.4 deaths in the first year of life per 100 or 1,000 live birth. And you can see the other industrialized nations, Sweden has 1/2 of what we have. But I think even more embarrassing and frankly unbelievable is maternal mortality. And what you see here is that in the United States, there are 26 deaths per 100,000 births. And that really is about 15 times what it is in Australia. I mean, truly. And frankly, there's been an unprecedented increase in these deaths. It's not that we've gotten better. You can see here from 2018, that's for 100,000 live births. And in 2014, it had gone up to about 24. And in Texas, it had nothing. So those are some of the problems, but there is also a high cost of healthcare. And when you look at it, going back to 1980, we were in the pack of the industrialized nations. Yes, we were probably, one of the most expensive. But what's happened since then is that, yes, all of these countries have had increases in their, costs. Probably having a lot to do with the technology in medicine. But we have just gone off the wall, and are sometimes twice as expensive as some of the industrial nations. But why is this? Well, maybe we stay in the hospital longer and just use up more hospital days, right? And one of the most expensive places that we spend money in healthcare is in hospital costs. But look at this, compared to, other industrialized nations, we are one of the lowest in terms of the number of days per person per year in a hospital. Well, maybe that's because, we just do some wonderful outpatient care, right? And people see the doctor more often, they don't have to go into the hospital. But look, we have one of the lowest number of visits per capita to the physician in the industrialized world. Well, maybe it's because we have too many old people. And old people are clearly the ones who use most of the healthcare dollars on that. But look at this, in terms of the population, percent of the population over 64, we have one of the lowest percentages of people over 64. It's not the elderly that are causing this huge price. Well, maybe the problem is that Americans smoke too much, right? And smokers end up requiring help. But look at this. The percent of the population over age 15 who smokes daily, we've done pretty well. We're among the lowest industrialized countries. And the Paris, France, oh my God, everyone out there France. But all of their data. But maybe it's that we pay our doctors too much. And what you see here is that particularly among the specialists, you know, Australia and the Netherlands actually on average are paying their specialists more than we are in this country. When it gets to primary care, things aren't quite so good. That's another issue. And when you compare us, for instance, with single payer Canada, what you find is that, look at this, the ophthalmologists are getting $804,000 per year. And, you know, the thoracic surgeons, $594,000. Even the internal medicine folks and family medicine, the internal medicine folks, $414,000. Yes, this is in Canadian dollars, so if you want to calculate it in relation to the US, these numbers are a little bit higher, but not that much. Well, in terms of really trying to find the reason for our high costs, this chart, I think, begins to suggest that. And what you see here in 1970, going up to 2022, the yellow line is the number of physicians and how they have increased in the United States. But look at what's happened to the number of managers, administrators, you know, bill collectors, and so on. They have just gone off the roof. And I think this data is really fascinating in terms of insurance overhead. You see that it's much, much higher in the United States than in the other industrialized nations, all of whom, by the way, guarantee universal access. And, you know, if you look at hospital billing, not just these insurance companies, but the hospital administrative costs in the United States and Canada, $1,200 compared to 2017 single payer. And I think this data is really remarkable when you compare Duke Medical Center with 957 beds in 3 hospitals, with Toronto University Health Network with 1,272 beds in 5 hospitals. Duke Medical Center has 1,600 billing clerks compared to the 7 billing clerks up in Canada. Wow, what a difference. And then looking at another study, US hospitals have the highest administrative costs in the industrialized world. About 25% of all US hospital spending consists of administrative costs, including the salaries for staff who handle coding and billing. Compared to 20% in the Netherlands, 16% in the UK, and really only 12% in Singapore. And one should say administrative costs aren't only in insurance companies or hospitals, but they're also in doctors' offices. Because doctors have to deal with the multiple private insurance companies, each of which have different criteria for what's medically necessary. And what you have here, you can see is the per capita costs compared to, And finally, there's a thing that we could spend a great deal more time on here. But it is the increasing corporatization and financialization of the US healthcare system. The US health sector is worth a lot of money. $4.4 trillion. And what's happened in the last few years is that private equity has begun to purchase physician practices. It's increasing. Private equity is a for-profit entity. Hospital system boards have begun to recruit more finance professionals to help them launch investment arms with their nonprofit revenues. And for-profit health insurers and pharmaceutical companies use share buybacks and spend $87 billion more on buybacks and dividends than on research and And although this is a 2016 slide, I can't hesitate to not use it. Because what you see here is the, CEO revenue, what we pay the CEOs of our major insurance entities. And I always like to point to Mark Bellini, who back in 2016 was getting $159,000 every day. Can you imagine that? Right. Now, he's no longer the chair of Aetna, because Aetna, as you all probably know, was bought by CBS. And he was asked to step down. But I wouldn't doubt the person who's replaced him is getting very soon. So I think our healthcare system is in real need of reform. Given the uninsured, the underinsured, the poor outcomes and the high cost of care, we've got to do something. And I would argue that principles that should guide healthcare reform are, number one, that healthcare should be viewed as a human right, that there should be universal access to healthcare, no financial barriers to care, that the coverage should be really comprehensive, covering all medically necessary, that hospitals, clinics, long-term care facilities, and nursing homes should all be non-profit. And finally, that funding should be progressive. So, what are the policy options that we're facing at this time? And I'd say they really amount to four. The Democrats and Biden. Fundamentally, what he has done is built on the ACA. That will explore a little bit more what the Affordable Care Act really is. Or they're the Republicans, and to some degree, I think Trump does represent them. And what they're about is wanting to privatize both the Medicare program and the Medicaid. And then we'll turn to more of a solution that I favor and improve Medicare for all people, not just people over 65, but even down to the infants that are born. And if you judge that that's politically impossible, one might want to consider, could we actually create a state-based single-payer program? And in New York State, we have a bill in our legislature that precisely would do that. And the idea that some people that advocate this point to is that in Canada, right, Saskatchewan was the first province to develop a single payer system. And it only took really 4 or 5 years after that for the entire Canadian population to say, we want a single payer system. So we'll as I say, unfortunately not have time to talk about states. So what is the ACA? The Affordable Care Act. I would say it's a mandate for a market model. Everyone is required to have health insurance or pay a penalty. Back when it was passed, you know, it was essentially, if you didn't have health insurance, you would have to pay $969 per year in taxes. And if you were a family, it would be $2,085 per year. And if you were an employer with more than 50 employees, and you didn't offer health insurance for your employee, you would in fact have to pay taxes of $2,000 per employee per year. Okay, but there are more aspects to the ACA. Because government actually, through the ACA, can help pay for health insurance. And here, Medicaid was expanded through the ACA up to 138% of the federal poverty level. That is, if you're an individual, $16,000. Family $27,000, but only 41 states actually expanded their eligibility levels. And let me say that I didn't look up Rhode Island, but New York, when in 2010, when the ACA was passed, we still had a federal poverty level of about 95%. Of the federal poverty, not even 100%. To make you eligible, you have to demonstrate that your income was less than 95% of the federal poverty. So going up to 138% of the federal poverty level expanded the number of Medicaid eligible people in New York State up to about 2 million people. So that was a major. And then the other thing was the establishment of private health insurance exchange. This would be on the state level, but there was also a federal level. And what would happen is that premiums would be subsidized by the federal government from 138% of the federal poverty level. That which up to 400%. So poor people would be able to buy into, private health insurance, even if their employer didn't offer it. And finally, there were the private health insurance market reforms that the ACA initiated, coverage up to age 26. On your parents' policy. So you can benefit from that. I know I should. No pre-existing condition exclusions or lifetime limits. That used to be that a lot of private insurance. And all private insurance must cover 10. So that's the ACA. But here's a diagram that describes what I just said. In terms of insurance reform, Medicaid expansion, exchanges, guaranteed issue, kids up to 6, better coverage. But we haven't really talked about a lot of the other delivery system reform, creation of accountable care organizations, what to do with dual eligibles, Medicare and Medicaid, value-based payment, and even federally. Little wonder that the newly elected president in 2016, Trump, he said, I didn't realize that company And this is because the Republicans were trying to, take it away. And they were only blocked by a few Republican senators who refused to do that. So, the ACA, however, accomplished a lot of things. 20 million people got health insurance, 12 million through Medicaid, private insurance. No pre-existing condition exclusions really made a difference in terms of private health insurance. Free preventive care, contraception, coverage of age 26 on parents' policy, and subsidized coverage from 138% to 400%. And Biden decided essentially to build on that background. Expand private insurance through for-profit health insurance companies, unfortunately. But that's what subsidizing premiums through the ACA exchanges does. Enable Medicare to negotiate for drug prices, and that's one thing that he's been successful about for 10 drugs, one of which is insulin, and now have it capped at $35. He wanted to improve the traditional Medicare program to level the playing field with Medicare Advantage, which meant coverage for dental, vision, hearing, and instituting out-of-pocket limits. Those things he has not. And further privatizing the traditional Medicare program by taking the Trump program, direct contracting entities, DCEs, and changing the name of these to ACA-Reach. What is ACA-Reach? It's an accountable care organization. And REACH stands for Realizing Equity, Access, and Community Health. Wow, that sounds pretty progressive. Like do something. But what it does is give an entry to the traditional Medicaid program to private health insurance. How does that work? Essentially, REACH places a middleman between Medicare and the patient. The middleman is a private equity or private health insurance company. In contrast to Medicare Advantage, which can only keep technically 15% of what they in fact get from Medicare, they can keep up with 40%. That's important. The patient is automatically enrolled without consent. So how does someone get into an ACO-Reach program? It's their primary care doctor who decides to enroll in ACO-Reach. And the patient doesn't have any ability to consent. That's very different from Medicare Advantage, where it is the patient that makes the choice to go into the program, even though with the level of advertising, one can sometimes realize that they aren't told enough about insurance. But with ACO-Reach, the only way that a patient can get out of the program is by changing doctor. And if you're in a rural area, how many primary care doctors are there? Not a lot. They all. So, like Medicare Advantage, REACH privatizes the public program. 10 minutes. Oh, okay. Really, go ahead. So there's a lot of shortcomings to the ACA. It does not guarantee universal coverage. There's still 28 to 30 million uninsured. The ACA is a market model. Cost control focuses on high deductibles co-payments, which results in rising rates under insurance. The ACA gives taxpayer money to private for-profit health insurance by creating these exchange programs. And the ACA does not stop privatization of Medicare programs. Traditional Medicare. So what are the Trump options? Very quickly, I think it would be, if you really ask, privatizing the entire Medicare. Expand Medicare Advantage to everyone who has Medicare. Maybe even convert the program into a thing called premium support, where vouchers are given to seniors to pay for private health insurance. They can go out and private plan that fits their needs. And continue the DCE program, which is, as I mentioned, program to privatize traditional. And frankly, Republicans want to really disrupt the Medicaid program by requiring work requirements, and convert all Medicaid programs to managed care. Many of them are managed care run by private insurance. So let's talk about what I think is where we should go. And that's to an improved Medicare for all. This is the vision that we should have, about where we are and want to go in the future. This is a single payer Medicare for all proposal put together by Physicians for a National Health Program, which we call the Physicians. And it has these 8 principles: universal coverage with automatic enrollment. You present to the emergency room of a hospital, you don't have any health insurance. Oh, let's enroll in the emergency room of the hospital. We deserve to get health insurance. Is there any private health insurance company that will enroll you in the emergency room of a hospital? And low administrative costs because it's a single payer and focus right on that about comprehensive coverage without copay, without deductible, no financial barriers. Maximum choice of doctor and nurse practitioner. Hospital improved quality through nationwide HIT, health information technology. One of our real limits right now is that private insurers don't share a lot of their data. And in fact, medical records are not easily transferred. So, you come from Providence and you're having a vacation in San Francisco and you get sick and you need to get care. They can't see the medical record. Then expand primary care because you could do that more from a universal coverage program. Lower drug prices because now you can negotiate directly with the pharmaceutical industry. You don't have to go through the pharmacy benefit management. And this is a publicly funded private delivery program. So how does the fair public funding work? Create a federal healthcare trust fund, transfer employer contributions, from to private insurance into premiums into the public trust fund. Develop a graduated employee contribution based on income and actually tax unearned income, such as stocks, bonds, gains, and so on. But no private health insurance premium because they're regressive. The president of the company pays the same premium usually as his or her secretary, yet their incomes are so wide. And we would argue that there's no increase overall healthcare spending because of the administrative savings. So where do those savings come from? Well, here you see it, Medicare has an administrative cost of somewhere around 2 to 3%. And private health insurance has anything from 60 to 30%. And $500 billion will be saved by converting for-profit private health insurance to a Medicare for all. And here is a study from the Rand Health Insurance. For a it's kind of interesting. What you see here is that reduced insurance administrative costs 2030. This is for New York State. And reduced physician and hospital administrative costs 16 million, and reduced costs because New York would have a population without 20 million that really negotiate directly with the pharmaceutical industry. So we would save $55 billion, but there would be increased costs. If we're going to cover everyone, even the undocumented, $17 billion, we're going to increase the amount of money that doctors, the providers get, because right now we believe they don't get enough to the Medicaid, maybe also the Medicare. And we're going to add long-term care, which now is covered in a meaningful way, except in the Medicaid program. So there would be in that savings. And improved Medicare for all would be run by a nonprofit private delivery system under local control. This is not socialized medicine. Doctors would not be employed by government. Hospitals would not be owned by government. That's what happens in the UK, which has its National Health Service. So, improved Medicare for all, single payer with no private health insurance that duplicates the public coverage. All hospitals, clinics, nursing homes convert to nonprofits and are reimbursed with global budgets. Physician reimbursement negotiated with doctors. Medicare negotiates for prescription drugs directly with the pharmaceutical industry. And long-term care, dental, vision, and hearing are covered with no need for gap. These are the bills that we have in Congress. We know that Diapol and House of Representatives, not surprisingly, Bernie Sanders, Senate. In the House, Vanilla has about 120 co-sponsors to her bill. Sanders has only 15. And when you ask people out there, do you favor expanding the universal coverage, universal Medicare for all? 60% favor that. All adults, 58% they say they're Democrats, even 20%. If they say they're independents, 60%, but there is even 30% of Republicans that favor. Last one. So, improved Medicare for all would essentially improve traditional Medicare service, no need for gap insurance, no financial barriers, no copays, no deductible, comprehensive coverage of all medical necessary care, no private for-profit insurance that duplicates the publicly financed through progressive taxes, delivered through a nonprofit health system. No limited networks, and real single payer health care system. And here are a few references that you might find useful, and some additional references. So let me stop there. I think according to the clock, it's back at 2 minutes. But, let's see what.
All right, great. Well, thank you so much, Oli, for that.